Hey y'all, it's Lauren, and you're listening to Social Workers on Fire. And as promised, I have with me today Dr. Crawford, who is our state medical director. And so, Dr. Crawford, I just kind of wanted to start out, give us your history, where you're from, previous jobs, how you got here.
Okay. I grew up in Greensboro, which is just a little small town south of Tuscaloosa. Um, Grew up there. It was a great place to grow up. It was a small town. And my wife and I are both from there. So when I was in the 10th grade, and I'm not sure they even do it now, but back then, all 10th grade high school students were required to take CPR. So the local ambulance personnel, the local guy that ran the ambulance service, Ralph Howard, he started the ambulance service there in '73. He came out and did CPR with us, and got pretty interested in that. And I said, "Hey, can I come ride with you one day?" And he said, "Absolutely." And I was 16 years old and was about to turn 17, and so he said, "Absolutely, come ride with us." So I don't know. Fast forward a month or two, and I went and rode one day, and the first call, I'd only been there just a few minutes, and we had a pretty bad trauma call. It was a car wreck. Two people hit a tree, and I guess the bug bit me at that point in time. So
Yeah.
I never looked back. So I worked. Lots changed, obviously, with regulations and things of that nature. But anyway, so I rode as a third person as a junior in high school. And back then, it was prior to National Registry for basic EMTs. You had to take registry for paramedics, but did not have to take registry for basics. So I rode and I basically learned a lot of OJT basically as a third person riding with Ralph. And when I guess I rode all through my junior year in high school and in my senior year, and I was playing football, and during football season he started an EMT class. Back then, lots of EMT classes in the state were taught out in the community, so he taught an EMT class. So I took the basic class, and I had not turned 18 yet, and I took the state test, and obviously passed the state test at that point in time, but the state would not give me a license until I turned 18.
Uh-huh.
So I had finished the EMT class and still rode throughout my senior year in high school. And then when I came to college here in '86, the fall of '86, the intermediate and paramedic level were taught at the university as part of the EMS program. That was before they moved it to the fire college. So I actually went through the intermediate. I went through the first semester. Back, of course, lots and lots have changed since then. But back then, the intermediate was 2 semesters. It was a semester of sort of didactics, classroom instruction, and then a semester of rotations. And then the paramedic was the same thing, 1 semester. It was only 2 semesters at that point in time. So it was a semester of classroom, a semester of rotation. So I went to the first semester of intermediate, and then I joined the National Guard. So I had to go off to basic training AIT. So I was gone for, I guess, 18, 19 weeks. And then I came back and did my clinicals.
Yeah.
And then went straight into paramedic at that point in time. So I was a paramedic at age 20, and and worked on the ambulance in Greensboro during that time. And Dr. Bobo was in the emergency department at that time, and I worked at Emergicare as well. At that point in time, he hired paramedics, at Emergicare. So I worked there a good bit as well as a shift supervisor, and we did basically the same kind of stuff. We started IVs, gave IV meds and things of that nature.
Right.
Learned an awful lot about medicine in general, and learned a lot because I was actually working with a lot of the emergency department physicians that were over at Emergicare on their off days and things. So I learned an awful lot of medicine during that time.
Oh, I'm sure.
And so then after that, I finished my degree and worked the whole time through college, working on ambulance in Greensboro. And Tony Smelly and I, who owns North Star EMS, Tony and I had gone to paramedic school together.
Oh, okay.
So when he started North Star, Edgar Calloway and I were actually teaching at the university. Dr. Bobo was the program director at that time, and he had actually hired us to teach. Edgar was teaching the paramedic. I was teaching with Steve Moffitt, who was a retired Tuscaloosa fireman. Steve and I were teaching the didactic intermediate, and then I was a clinical coordinator for all of the levels, basic, intermediate, and paramedics. We'd have, over 100 students a semester that we were trying to get through the rotations. So I worked at the university as well, teaching the programs. A lot of the guys with Tuscaloosa Fire, many of them, most of them have retired now that we taught actually.
Right, yeah.
But anyway, so that's sort of what we did, and then I went to medical school and went to Birmingham for medical school. When I finished medical school, they did not have an emergency medicine residency in Alabama. They do now, but they did not at that point in time. So I went to LSU in Baton Rouge and did my emergency medicine residency, and then I came back here in 2000 and started working in the emergency department. I've been in the emergency department since that time.
So you always knew you wanted to be like in the emergency room ER when you went through medical school?
Yes.
Okay.
Yes, I absolutely. I
Okay.
never looked at anything
Any
else.
other specialties?
No,
Okay.
not at all.
I heard, though, that at one point you thought you wanted to work for the fire department.
I came very close to coming to working with the fire department when I was in college, and I was obviously I was a paramedic then, and I really many people don't get in medical school their first year,
Right.
and it sometimes takes a couple rounds to get in, and I really wanted to go to medical school, but I thought, if I don't get in, or if it takes me several years to get in, I can go to work in the fire department, and so I actually came as close as I actually went down to City Hall and actually got an application.
Oh my goodness! So you were real close.
I was very close, and never took the test. So yes, I was pretty close.
So how long have you been the state medical director?
Since 2011.
2011.
I was assistant medical director from 2005 to 2011, and then Dr. John Campbell, who was just one of the pioneers of EMS and pre-hospital EMS in the country, really, but certainly in the state. I was his assistant from 2005 to 2011, and then in 2011 he retired, and I took over as the medical director in 2011.
Okay. So for those that are listening that aren't in the medical field, they're probably more social workers. Could you explain, what is your role as a state medical director?
Sure. We have roughly 13,000 licensed personnel in the state as far as EMS. That's, EMS, EMT basic. We still have a few intermediates left and advanced and paramedic. And my job is sort of to be the medical authority for the Office of EMS. The sort of the hierarchy of the EMS office. We're part of the health department. And the hierarchy with that is that we have a sort of an executive director. He's not really, he's just called a director. He's actually a paramedic. And then we have a medical director. He and I work in tandem to sort of, develop protocols. And we have some subcommittees that we lean on. We don't do them all by ourselves. I mean, we've got some other physicians that we will lean on. We actually have two other physicians that sort of work underneath me. There's one that's a trauma consultant, one's a pediatric consultant. But we develop protocols. Any of the sort of the any state agency has to have rules, and
Right.
we develop those rules. And really just running the day-to-day operation. There's always an issue that comes up. We always have, unfortunately, we have complaints from the public that just like anything else, so we handle complaints, we handle compliance issues. We handle variances. Sometimes if one service, just can't get this medicine or that medicine, they've exhausted all avenues. So we run herd over the variances and assist that. And we make sure that these, the protocols are rolled out. So it's really just more of an administrative role.
Right.
But if there's a clinical issue or a clinical question, then they'll call me, and we sort of all of us together within the health department. Sometimes we lean on other offices within the health department. So it's more of an administrative role,
Yeah.
just sort of running, herd over the whole EMS system, I guess, in Alabama. And we have an acute health system that's made up of trauma hospitals and stroke hospitals. And we have to make sure that those are certified and as per our state rules. And we visit those hospitals and revisit them and recertify them we try to do it every 3 years. We've sort of extended that period because we think 3 years is probably a little too probably too aggressive. So
Right.
we do a lot of visits, and a lot of it's relationship building because we're out in the community, and I've been in Anniston this week, and I'll maybe we have several out of state hospitals as well.
Yeah.
So I may be in Chattanooga one day, I may be in Columbus, Georgia another day, maybe in Tupelo another day, visiting those hospitals. So a
Yeah.
lot of what I do is relationship building.
So that was really a question I was going to ask, which I think you kind of answered there is like, do you have a typical day to day of what your day looks like, or is it always different?
It's
You're
always
just on the go.
Yeah, it's different.
Okay.
Always.
Okay. And this is kind of outside of your job, but the real question we wanted to know is how do you manage being the state medical director, but also having 8 children?
I have a great wife.
I knew that was coming.
My wife does a great job of handling most of that stuff, and of course I have to do my share of it too. So I've got great kids. I've got one that's actually in EMS as well. He's an
Okay,
advanced
awesome.
EMT. I've got one that's wanting to go to into the fire service, so he's about to graduate high school. But I have a great wife that handles a lot of. She can wear multiple different hats. And I wear a lot of hats, but unfortunately I'm not quite as good as her. But I wear one hat at a time with just multiple hats sitting on the shelf that I can pull on. She's got 4 or 5 hats that she's wearing at one time.
Oh, yes.
So
Yes.
I guess that's the short answer of it.
So, being the state medical director, what are you seeing as the gaps in care?
I think several things. I think one of the things that we're seeing is we're seeing some of these smaller hospitals either closing or reducing services, which translates into especially the rural EMS services are having to transport patients further, leaving the communities uncovered. I think that's one of the things that we're seeing. I think two, during COVID and after COVID, just people just got out of EMS.
Yeah.
I think we're having a workforce distribution problem. Now, lots of people say, well, we have a paramedic shortage, and I disagree with that. We don't have a paramedic shortage in Alabama. Now, lots of people are gonna throw rocks at me when I say that, because we really don't. Because if you look at our numbers have been consistent. We have approximately 6,500 paramedics in the state of Alabama, and that has been consistent. It'll give and take. 200. We'll lose
Right, a
200
little
this
bit.
year and
Yeah.
gain 200 the next year, but that's a pretty steady state. We have a distribution problem. I still have a paramedic license. I still maintain my paramedic license. So on the roll, I'm a paramedic.
You show up.
But I don't do paramedic work.
Yeah. Yeah.
So lots of people continue and keep their paramedic license current, but they're not working as a paramedic. We have a distribution problem.
Yeah.
Is what we have. And unfortunately, COVID sort of exposed a lot of that, and then other people that during COVID just got fed up with it. They didn't want to do it anymore. They got burnt out, whatever term you want to use to describe it.
Yeah.
And they just left the field. So they still have a license, but they're not working in the field. So it's a distribution problem. So I think it's a workforce issue. I think that's one of the biggest gaps that we have right now. I think billing and reimbursement is huge.
Yeah.
And I think the reimbursement issues are not necessarily for the fire service, but for the private EMS service. It's really taken a toll, because many of these places are working, on a shoestring budget. They have to buy a set of tires for an ambulance this month, then they're going to have problems making payroll. And lots of people don't understand that. So I think the reimbursement. That's getting a little bit better. The ambulance association here in the state has really become much more involved in the legislative process, and they are really trying to push their their interests, which we certainly agree with. They're trying to make the legislative folks aware that, hey, we're at a crisis from a reimbursement standpoint. So I think locally here, I think that we have a mental health issue, and that's where y'all come into play many days. But I think that when the state closed the mental health institutions, or closed a lot of them,
Yeah.
I don't think there was a great plan in place, or maybe there's a great plan, but it just didn't. The plan didn't work out, where many of those people don't have great community care,
Right.
and they're unfortunately showing up in the emergency department. They're calling EMS, and many of these frequent overutilizers, I guess, whatever term you want to use, of EMS and the emergency departments, has a social issue with it. That's I mean,
Yeah.
I'm preaching to the choir,
Oh,
but y'all
yes.
know that, and
Yes.
and they come to the emergency department because that's what they've always done,
Mm-hmm.
and we have to be able to take that and sort of cut that and break that cycle, because if we don't, we're just going to continue, because the next generation does the same thing, the next generation does the same thing, and
Yes,
then we clog
definitely.
up the emergency departments with really non-emergent patients, and then I can't get to the true emergent patients. And the same thing with EMS.
Yes.
We've got a rescue truck or a fire truck out on a call that's non-emergent, and then they get a cardiac arrest in their territory, and then somebody's having to come from another station, another territory to cover it, and the response times are delayed, and on and on and on. So I know I'm preaching to the choir about
No,
that, but
no.
I think those are the gaps that I see: reimbursement, distribution problem with paramedics, and the increased reliance of EMS and the emergency departments for social issues that really could be handled in a different manner.
Yeah. And I think that kind of leads into my next question. I know you addressed the mental health aspect, but with what you're seeing in the ER, what else are you seeing and how it relates to EMS prevention?
Well, again, I think that we're seeing a lot of these people who are coming in because they just don't know where else to turn,
Yeah.
and they're coming into the emergency department. I think the diabetics are an issue. I think people are having difficulty managing their diabetes at home because of a social issue. Maybe maybe they don't have family. Maybe their living conditions are such that they just don't have a way to get their medicines. Maybe they don't have family to help them. Maybe their income doesn't. Maybe they don't know to get on some assistance program so that they can get their insulin. So what happens is their blood sugar goes up, and they come to the emergency department, and they're in DKA, and then I
Yeah.
treat them, and then they're in the hospital 3 or 4 days, and then they go home, and if nobody really takes that and runs with it and gets them the help, then guess what? 2 weeks, 3 weeks later, they're going to be right back in the emergency department with the same thing, and it's just a vicious cycle.
Yeah.
So I think that we have to do a better job as a as sort of the whole system in the emergency department, in the hospital before discharge, in the EMS, and I think the guys here, with Tuscaloosa, I think the company officers and the guys that are riding these these fire engines, I think these guys are doing a really good job of identifying those patients that they're running on,
Yes.
and notifying y'all so that y'all can get involved. But I think if we don't do a good job up front, then these people enter the system, and they don't have the money, they don't have the resources to get their medicine. And I use diabetes, but it's the same thing with hypertension, same thing with congestive heart
Oh,
failure.
yes.
And the
Yeah.
congestive heart failure is a huge issue because these people just continue to come back to the emergency department, and we don't mind seeing them, but the problem is they could be treated on an outpatient basis.
Yes.
But many of them just don't have the resources to get to their doctor's appointments after discharge. They don't have a avenue to get their diuretic or their blood pressure medicine, and many of them just don't have the education from that that condition. They haven't been educated about what they can and can't do with congestive heart failure.
Mhm.
You can't, you can't eat 3 bags of potato chips a
Right.
week.
Yeah.
It's going to increase your sodium level. So I think that's the thing that we see day in and day out is that many of these patients are, you know, they have true medical problems, but many of their medical problems are exacerbated by the social issues and the
Yeah.
social things that they're unfortunately faced with. So I think that's where we have to move the needle is making sure that hospital we had to break down barriers, and we had to break down silos. In the past, it's always been when the hospital has here, we discharge them and really don't do a great job of following up. Um, you know, EMS side, we don't do a good job of historically partnering with the hospitals and saying, hey, we're seeing this patient. Hey, will you let us know when these patients are discharged so that we can go
Right.
out and visit them? Things of that nature. We have to break down those barriers. We have to break down those silos. It has to be a system approach to taking care of these patients rather than a silo here, a silo
Yeah.
here, a silo there. And that's the only way you're going to move the needle and make these people get the care that they need. And in turn, you're going to reduce the sort of the non-emergent calls that you're going on in EMS, which equates to having more ambulances and more rescue trucks and more fire trucks, et cetera, that can respond on those true emergencies. And you're going to reduce the backlog in the emergency department.
Yeah.
And it's not a unique thing that we're seeing here. I talked to a lot of folks really all over the nation, and the same challenges that we're seeing here, other people are seeing them all over the nation. So
Oh,
we're not
yeah.
unique.
And I think, you're talking about where we're not silo here, silo here. It kind of reminds me just even yesterday where we're starting to break down those barriers and work together. Is just yesterday we got a call from a worker at the hospital saying, hey, do you know of this person? And we did. It was actually one of our clients. And it's like, okay, what are you working on? Let's work together.
Right.
And then giving them my number. Hey, when they discharge, let me know. So then I can go out there because sometimes they're hard to catch because they're quickly going back to the hospital. And so I think we're really seeing a change as now we're starting to build those relationships with the case managers out at the hospital and at North Harbor. And so that's, like you said, that's where you're going to see the difference is when we're not our individual entities, but we're coming
Absolutely.
together. So
I'm fortunate. I get to see a lot of different, I guess, views of the EMS system and the medical system in general because I get to travel a lot of places as a state EMS medical director, and I think we've got a really really good system here in Tuscaloosa. I think the system works extremely well. We're not perfect by any stretch of
oh
imagination,
no,
but
yeah.
I think we do a really good job, and I think we work together well. And again, I think I'd like to take this time to, from my standpoint, um, I certainly appreciate what everybody does. I try to take that opportunity every time I talk to anybody. People don't know, the community has no idea what EMS personnel do. They don't know
Yeah.
what y'all do.
Yeah.
And I take every opportunity to thank the people for doing what they're doing because I look, I know I've been there and I've done it for a long time. They're missing their families and missing birthdays and anniversaries and holidays and all kinds of things, and they're seeing the worst of the worst.
Yeah.
And people don't thank them enough. So I certainly appreciate what everybody does.
Yeah. I know they appreciate hearing that. Sometimes it can be a very thankless job and they're doing the hard work. So before we wrap this up, we just want to kind of ask you if someone from another fire department or another hospital were to approach you and ask about EMS prevention and what we're doing, should we start that? What do you think you would say?
I would answer it in a couple different ways. I think the the overarching, I guess, answer would be it reduces the non-emergent calls that a fire service or fire department is going on. If it's done right, if the company officers and the crews on the pumpers are identifying these patients, that hey, we're going on these patients, you know, 13 times a month. There's got to be something. And then they're in these houses all the time too. I mean, and they're seeing, hey, these living conditions are really poor. I've talked to this patient, and this patient says they just don't have the money to get their medicine. And if they're doing their part, and they are, and we've been extremely fortunate for our guys to embrace this and to refer people
Yes.
to y'all.
Yes.
So I would say that that assists the fire department in reducing the calls that they're having to go on that are non-emergent calls, that are really social issues. And just as we've already talked about, that sort of parlays into one, I think it helps a morale issue because, hey, guess what? You're just not beat down at the end of your 24-hour shift
Yeah.
by going on these patients that you really have no reason to be going on other than they just call. So I think the morale issue, I think I look at a lot of different avenues, but I think from a risk assessment, it reduces your risk because look, every time, especially if you're going out and you're running lights and siren, if you can
Yes.
reduce those times that you go out with lights and siren, it's going to reduce the risk to you personally. It's going to reduce the risk to the city, reduce the risk to everybody involved. I think it keeps the rescue trucks and the fire trucks and everything else in place for those true emergencies, those true time sensitive issues, house fire or, apartment fire or, cardiac arrest or gunshot wound that unfortunately we're seeing more and more of. So it keeps those vehicles and those personnel uh, ready to respond to those true time sensitive issues.
Yeah.
So I think from a RAL standpoint, from a risk reduction, from just a readiness standpoint, and also I think it helps you from and again I don't get into the finances, but I think it helps you from a financial aspect from the city because look, you're not the wear and tear on your vehicles, the gas and everything else that you have to go out on all of these non-emergency calls or non-urgent calls.
Yeah.
But I think if you had to hang your hat on one thing out of all of that, from the crew standpoint, I think just a morale, just a reduction of the beat down factor.
Yeah.
Because they're just
Yeah.
beat down. They don't mind. Look, no paramedic and no firefighter minds going on those true emergency calls. They don't mind that.
Oh yeah.
But they get beat down by going on those calls that they know they there's no reason to go on, but we go on them. So I think if I had to say and tell another fire department what's the benefit, I think it helps your morale, and ultimately that helps the patient too because look, the patient, we still have to keep a patient-centric focus, and we still have to make sure the patient gets taken care of. And we can take care of them in a lot of different ways. It doesn't necessarily have to be in an emergent,
Mm-hmm.
way. We can take care of them, downstream. And I think that it assists and gets that patient taken care of in a non-emergent way, in a non-emergency department way. So I think, I guess if I had to hang my hat on one thing, helps the morale, helps with that patient because look, quite frankly, y'all know much more about the resources available to that patient
Yeah.
from a diabetes standpoint and the hypertension medicine and the getting rides to the doctor's office than I do. Because look, when I'm in the emergency department, I discharge them. I tell them, look, you got to go see your cardiologist. This is the
Mm-hmm.
third time you've been out here with CHF. You got to see your cardiologist. Well, guess what? I'm moving on to the next
Yeah.
patient. I don't have the time to set up a referral to somebody to take them to the doctor's office.
Yeah.
So
Yeah.
unfortunately, I think we drop the ball sometimes with some of that. And I think with the EMS prevention program, I think y'all know the avenues to get these patients taken care of so that they're not just continuing to enter the system every third or fourth or fifth day. So that's what I would sort of tell
Yeah.
another fire service that they or fire department they ask.
Well, I appreciate it, and I agree. I think it'll help them as well. Well, we so appreciate you coming on with us today and just sharing your knowledge and your views of everything that's going on and how we can help.
I appreciate the opportunity.
All right. Well, if y'all will tune in to our next podcast episode, we are going to have actually one of our student interns come on and explain what our students do on a day-to-day basis and how from there it inspired him to bring it to his community. And so we hope that you'll tune in.